All right, good morning, everybody. It's my pleasure to introduce Dr. Alison Kaufman. She's a public health advisor in the Communicable Disease Control Division of the Dutchess County Department of Behavioral and Community Health. I don't know how you get that to fit on a business card.
It's brand new, a real challenge to have it roll off the top.
She's responsible for the surveillance of zoonotic and arthropod-borne disease, and she's currently overseeing the county's response to the Zika virus. Dr. Kaufman spent 13 years as a practice in horse veterinarian before assuming her current role. So welcome to you, and thanks for coming, everybody.
Great, thanks for having me. So what we have today is an overview of tick-borne disease, mostly focusing on Dutchess County and then branching out somewhere from there. I know that anyone that has lived and worked in the health professions in Dutchess County, tick-borne disease is not a new thing. So the goal today is to not get through every single detail on all these slides or every single aspect of each disease, but more so to focus on updating you on the epidemiologic trends, and also just bringing up a few points that have come up that we want to make sure that clinicians are up to date on, things that you've seen in the press, and et cetera. Okay, so our general overview of the way we're going to run this, we'll start with the geographic distribution of ticks and tick-borne diseases in the entire country, and then we'll kind of come down, get it more narrow to Dutchess County, and talk a little bit about the diseases that are well established here that you guys are probably seeing. And then at the end, we'll touch on some things that have been newly recognized that may or may not be here, but we want to have an awareness of because they could become our reality in the future. If anything that Zika has taught me over the last few weeks is that something can go from being quite obscure to being very relevant and everyday quite quickly. So, all right, so this slide is basically a list of the infectious tick-borne diseases that are present in the United States. It's mostly comprehensive. This is a list you'll find on the CDC. The left side of the screen has the diseases that are endemic in our area, and the right side of the screen has diseases that are found in other parts of the country. And so we're going to talk about some of the ones on the right side of the screen, and basically what I want you to note is that where diseases occur is directly impacted by what ticks carry them and what the geographic range of those ticks are. So when we think about, when you hear something in the press about a new tick-borne disease that's been found, you want to think about what tick carries it, and is this the tick that we have here? And then you can kind of say in your head, well, how much risk do we have of seeing this, and or again, also thinking about travel-related cases as well. So on the left-hand side of the screen, the diseases are mostly listed in the order of the most common in our area to the least common, with the exception of Borrelia miyamotoi, which I put at the bottom because it's not yet a reportable disease, so we don't really have an idea on its incidence at this point. Okay. So then I just wanted to slip in here that there is at least one non-infectious tick-borne disease that we should all be aware of, and particularly with your patient population you should be aware of, and that's tick paralysis, and that is a ascending paralysis that's caused by a toxin in the saliva of gravid ticks. And again, this is not a particularly common disease, and it is not particularly common in our area as well, but there have been 2 cases in Dutchess County since 1995, and the epidemiologic studies do show that the patients most at risk are children, particularly girls under 10. And the nice thing about this disease, in contrast to most of the other records that come across my desk of really horrible neurologic conditions that happen to people, is that this is highly curable. All we have to do is find the tick and take it off, and people get better, and that is commonly not the situation for really aggressive neurologic conditions. So this is something to keep in mind if you're looking at a case that you're thinking might be a Guillain-Barré syndrome or something of that sort. To keep this in mind and make sure you do a tick check as well. All right, so this is our overview of the ticks that can be found in Dutchess County that carry disease. Again, it's listed from the top to bottom, from the most common tick to the least common. The top is our old friend Ixodes scapularis, otherwise known as the black-legged tick or the deer tick. It is the carrier of most of the diseases that we see with regularity around here. The American dog tick is the second most commonly found tick. It can also carry Rocky Mountain spotted fever, which we see not too commonly, and tularemia and tick paralysis. The Lone Star tick in the past had been thought of as being more of a southern tick, but its range is expanding northward, and it does carry some other diseases that we do see. We do see a small number of Ehrlichiosis around here, so it is one to be aware of. And then at the bottom is the woodchuck tick, Ixodes cookii, that is in this area. It does carry Powassan virus. We'll talk about that more at the end, but we need to keep in mind that this is a tick that doesn't like to bite people. You have to work pretty hard to get bitten by one of these, so they've, people that have been bitten have been like cleaning out squirrels' nests or actually going into the groundhog hole and pulling out the groundhog. So these aren't ticks that wander around in the woods and jump onto other things. So when my neighbor at the health department had to arrange for rabies prophylaxis for someone that pulled the groundhog out of the hole and got bitten, then, you know, that's the patient you might want to consider might get bitten by this tick, but not the majority of us that run around in the woods. Go ahead.
Reading the Lone Star tick causes that alpha-gal beat sensitivity. Have you heard about that one?
I have heard about that, but I don't know a lot about that. But I definitely have seen that in the press. So, yeah, you know, if you start reading every day, you'll find another thing being blamed on ticks. But
that one I think is true from everything I've read.
Yeah, and well, a lot of them are probably true. Exactly how handle we have on it. Do you remember, Andy? Do you remember reading if it was the Lone Star tick that was particularly implicated?
The Lone Star tick is implicated.
Yeah. They really always finding something new that these guys do that can cause us problems. So that's a really yucky slide, so we won't stay on it for too long. All right, so the first disease we're going to talk about is Lyme disease. I'm not going to go into you guys have heard a lot about Lyme disease here, so we're going to kind of do some highlights here and not get too caught up. I love these slides from the CDC. This is basically showing the geographic distribution of reported cases of Lyme disease. If you go through these slides and you can kind of click year to year to year, it's really amazing to just watch the dots expand and spread out over the years. This slide is here basically to show that Lyme disease, so in 2014, it was the fifth most common nationally notifiable disease, but you'll see that if you think about that for living in our area, where we're seeing the vast majority of cases, then really this is I think chlamydia is the first, but this is really up there in terms of being the disease that we are seeing the most. So the Northeast, the Upper Midwest, we really are bearing a disproportional burden for this disease. And the other thing that you might have seen in the press as well is that with Lyme disease, perhaps even more so than with some other infectious diseases, we know that the reported case numbers are probably not an accurate representation of the real burden of disease. And, you know, we know this. This is something that's accepted because of just the nature of what it takes to report and get a case to confirmation. And so the CDC has done a couple of different studies to try to get different estimates on a different basis of what the true burden of disease of Lyme disease is. They've looked at insurance claims and lab reports, and so they've published a number of about 300,000 cases per year that are diagnosed with Lyme disease by a physician. And so really...
So it means that the number of cases that we know about is lower than
the number of cases that are reported, that are reported and become either a confirmed or a probable case, and so what that gets into is the difference between counting the number of cases that that a doctor will code or write in as diagnosed as Lyme disease versus cases that meet criteria by case definition. And so when we're counting, this is what we like to do, right? At the health department, we count things. We like to prevent things so that we have to count less, but we really like to count things. So when we're counting, we have a case definition, and there's one definition for a confirmed case, and that, and this is for any disease, not just for Lyme disease. By the case definition for confirmed, we have to have a pretty high confidence that we have the diagnosis correct, and then there's probable cases and suspect cases depending on the disease, and those criteria basically reflect the degree of confidence that the diagnosis is what it is. And that's a really different thing than what a clinician does in the exam room, and I think that's a really important distinction to have. I have been a clinician, you know, for animals. It's a little different than people, but some things remain the same. So the level of confidence that you have to say this patient would benefit from treatment with doxycycline, and I think that this is probably Lyme disease, is a different level of confidence than we have to make a case confirmed for counting purposes, and that's appropriate, right, because the goals are different. And so I think that's partially what's reflected in the numbers, and then the other reason why these numbers are lower is something that you know, we're very interested in discussing with clinicians in general, and that's just the level of reporting. So when I say level of reporting in New York State, when there's a reportable disease that has a positive lab result, we at the health department get notified through a system where all those positive reports come to us, and then that generates us starting an investigation and contacting you guys. It doesn't work like that in every state, but that is how it works in New York State. And so, so that's one way that we know about cases. But in Lyme disease, I'm sure that you guys are probably diagnosing cases based on an erythema migrans rash alone early in disease, and those cases won't be positive if you go to test them. And so those are the ones that if you don't, we don't have any way of knowing about that if you don't tell us about them. And so when a disease has been in the population for a long time and you guys are seeing it in high volume, we know that something called reporting fatigue happens over time, and that we have started seeing very much fewer reports from providers of EM rashes, and so that certainly contributes to underreporting as well. Does that answer your question? Okay, great. I think that's what I wanted to say on there. So this gets to what I was talking about. This is just case numbers for Lyme disease over the years, and you can see that in 2008, the case definition was expanded to include probable cases. And so if you look at the case definition for Lyme disease, in order to be a confirmed case in our neck of the woods, an erythema migrans is enough to confirm because we are an endemic area. But without erythema migrans, you need to have both positive lab works by the two-tier test and and at least one of a set of different symptoms that we'll get to in another slide that we know definitively are frequently seen with Lyme disease. And so that confirmed case definition might not catch some of the cases that you diagnose that come into the office with flu-like symptoms, and they don't have an erythema migrans rash, but you feel with clinical confidence that it's Lyme disease, and so that is reflected in the expansion of the case definition to include probable cases, which are basically doctor-diagnosed cases with positive labs. Okay? So what you'll see is that the rates of Lyme disease are definitely going up in the country. You have to look at it in relation to the knowledge of what the case definition was from one year to another. But I think it's also worth noting that perhaps what you hear, if you read some of the articles in the lay press and the media, you would think that this was like an explosion going off the graph. And so they're going up, but maybe it's not quite as explosive as the way it's expressed in the lay press. So this is a particularly important slide for this population because what you can see is that the age distribution for Lyme disease is a bimodal curve, and the patients that you guys see are at greatest risk. And it is important to note that this curve is not similar for the two other most common tick-borne diseases that we see in our area. For Ehrlichiosis and for babesiosis, risk increases with age, and so it's my guess that you guys are probably seeing relatively few cases there. So for Anaplasmosis, Ehrlichiosis, babesiosis, we think that that risk relates to a higher number of people with immune compromise as they get older. And we can talk about that more later. But for Lyme disease, we think that this spike in risk in those early years is kids that like to roll around in the leaves in areas where ticks are most prevalent, and so that's just an exposure risk, essentially. So this is what I was talking about before, the sort of classic symptoms that we associate with Lyme disease that are used as a part of the case definition to get to that level of making it a confirmed case by the epidemiologic case definition. And so you'll see that the majority of cases are with an EM rash. We talked about the importance of trying to get some of those cases reported. And I think I essentially talked about what I wanted to for this slide. All right, so this is our Dutchess County numbers, and so you can see that the number of cases of Lyme disease is fairly steady over time. We did have a spike in 2014. The 2015 numbers should be out relatively soon. We don't have them quite yet, so we'll start to see whether that was just a bad year or whether our levels are going to stay higher or not. The one thing I do, yep, go ahead.
Just a question. For those, like, quote, Lyme specialists in our area who I think don't necessarily use the same criteria that most mainstream practitioners use to make this diagnosis, and probably see a disproportionate number of AIDS patients and are diagnosing them, how do you think that could potentially be skewing your data?
Well, we're using the same case definition regardless of what doctor is running the lab work. I'll tell you that overall, I don't think I get a lot of Lyme reports from those doctors, and I think that that might be because they are using labs that are not the mainstream labs and thus are not certified and are not participating. So I think that
because those people aren't really reporting their cases.
Yeah, there's a lot of, so I think that there is a high level of understanding, not only at the county level, but at the state level and also at the national level, that there's a lot of, that Lyme disease surveillance is highly problematic. And so Andy and I have listened in on conference calls of the, let's see if I can get the acronym right, the College of State and Tribal Epidemiologists, who are once again trying to update the case definition for Lyme disease, not only looking at the case definition, but trying to deal with some of these challenges for having numbers that are meaningful. So I think that there is wide acknowledgement that the way that we count cases of Lyme disease perhaps does not give us the meaningful numbers that we want. And so, but like many things with Lyme disease, it's tough, and it's tough to find a way to do it best. Yep, go ahead.
In the same vein, how do you cope with the latest legislative idiocy, the full protection for Lyme quacks law they just passed, and you know, I mean, how do you deal with that? I mean, it's political. It's like the idiocy that make a sign report, you know, requirements to put sunscreen on children.
Yeah.
I mean, does that impact? I mean, it has to impact you.
I would say it impacts us because people want us to comment on it, and we try to remind the press that our purview in public health is that we count things and we try to prevent things. And so we don't think that it is our place to get involved in the debate over treatment. that is probably going to happen at higher levels of government and with research. And I'm sorry if I'm shirking your, but that is truly that is the way that
moronic, and you're stuck with it, just like so many health-related laws.
Yeah. It's tough. Lyme disease is a tough environment to work in, and I think that we all appreciate that. And even and I'll say, even in veterinary medicine, it's the same.
I will jump in. The biggest impact that those providers have on us is for Alison, is they screen for Q fever and brucellosis and on a regular, and so they just throw that in, and for our system, we get a call because they're considered BT agents, bioterrorist agents.
Yeah.
So we have to act on those immediately, and they usually end up being nothing.
Yeah. So
the same labs have never found a negative result?
So those results from those labs we don't see. They don't come through to us, but for some of these other tests, they are using mainstream labs, and so I will see these low titers for things like the latest one this year was, oh, maybe brucellosis is a tick-borne disease. Brucellosis is not a tick-borne disease. And so what I'm seeing is this sort of broad screening for diseases that are very, very rare, and what I told Andy that I was thinking about putting this slide in here, but I didn't do it. But putting in a, sort of a basic slide that shows, well, how do you figure out predictive value positive for a test, and that if you know that your prevalence is very, very low and your sensitivity is this and your specificity is that, that essentially running that test, you're going to, for the prevalence of some of these diseases like brucellosis and Q fever and tularemia, the test is going to be worse than flipping a coin. A positive value is completely useless. And so I understand from a provider's, I try to go back and put on my old clinician's hat and understand what it feels like to be in a room with somebody that has symptoms and is ill and wants an answer. And so I do understand the temptation to be like, well, we're going to screen for everything and try to find an answer for this person, but that doesn't change the math of what a predictive value positive is. And so so what Andy said is that functionally what these doctors do is that I spend a lot of time chasing imaginary diseases, and Wadsworth spends a lot of time doing confirmatory results on those that they come up negative.
Could you just comment on, you said arthritis was a cause. It's not arthralgia, right? It's arthritis.
Well, what the case definition is essentially, they call it arthritis. In my mind, I wouldn't necessarily, you don't have to have radiographic evidence of change in the joint.
You have to have a swollen hot joint.
You have to have a swollen, you can confirm if there was a prior history of swollen hot joints that progressed to being chronic arthritis. It's really hard for me to capture that based on the forms that we use where you guys fill out. So for instance, if somebody fills out a Lyme disease reporting form and they circle arthritis without joint distension, then that's not necessarily telling me that this person started with multiple bouts of arthralgia with joint distension and then moved to that. And so in my...
Without joint distension is not arthritis. It's arthralgia. There's a difference. Put in your forms that arthritis is a person with an achy joint.
Right.
My joints are aching right now.
Right. So I'll tell you.
I worked out last night and I'm old, but I don't have Lyme disease.
Right. So I'll tell you that the cases that come in reported to me like that don't make the case definition. They'll get called a suspect case. So the one other thing that I wanted to touch on for Lyme disease surveillance is that this slide is titled Estimated Incidence, and the reason for that is that in Dutchess County we do something called Sentinel Surveillance. Is that something that this group has heard about or knows anything about?
No.
The answers are no? Okay. So just really briefly, without going too far, what that means is that because we are a hyper-endemic area and we have so many cases, and so, but really so many positive lab reports because doctors are testing so much, that the volume of reports that we would get if we were doing full surveillance would be in the thousands, and that's physically unmanageable for any local health department. So New York State has developed a system called Sentinel Surveillance where we will investigate and count any of the cases that you guys report to us, whether that's an EM rash or whether it is a case diagnosed on a different basis. But in terms of the reports that come in simply from a lab positive, they are sorted up at the state, and randomly we get 20% of those to investigate. And then based on how those cases are disposed, what category I put them in, the state puts that into an algorithm, and that's how they come up with the total number of cases for the county for the year. So that's why when you see graphs like this for the epidemiology of Lyme disease, they'll say estimated case count for sentinel counties like Dutchess County, and the other counties in our area that are hyperendemic do it the same way. Okay, so, and then this is basically showing the Hudson Valley counties for Lyme disease. You can see that Dutchess is running in the middle, and I think that again, I don't put a lot of, sometimes I get a call where somebody says, should I buy a house in this area because of the Lyme disease rates higher here or there? You know, similar to that call, which is very highly specific, which clearly I can't answer, I would not look at this graph and say, oh my God, I don't want to live in Putnam County versus Dutchess because Lyme disease rates are so much higher. So I wouldn't take the interpretation of this graph to that level, if you understand what I mean. So, so how much Lyme disease there is it's really local, all right? And if there's more or less in a county, also I think we talked about with some of these reporting issues, I think that you can only read into this to such a degree, okay? So we're going to go on to anaplasmosis and babesiosis. How am I doing on time? All right. So again, as I said before, this is anaplasmosis is the second most common disease that we see in our area, tick-borne disease. But again, these are not things that you're probably seeing in your patient population to the degree that you're seeing Lyme disease, not only because it's not as common as Lyme disease, but also because risk increases with age. So we're not going to go too crazy on this, but the points that I wanted to make off of this slide is that while we do have two different organisms, anaplasmosis and Ehrlichiosis, clinically they present essentially the same, with the one difference that in children, rash is more common in Ehrlichiosis than it is with anaplasmosis. But essentially, this is going to be a laboratory diagnosis to try to differentiate the two. And the one point that I want to make on that is that in acute disease, the serology is going to be negative for these. So really, the best diagnostic to be using in acute cases, so less than a week after onset, is PCR, and PCR can confirm the diagnosis. And I will say that the same can be said for babesiosis, that we can, that there is a PCR test that can confirm in early stages of disease. And I have noticed that providers have picked up and are using the PCR test for babesiosis pretty steadily, but I have not noticed a lot of use of it for anaplasmosis and Ehrlichiosis. So I am curious if that's something that you guys are just not as aware that it exists, or if it's an issue with access through the labs, getting access to that test. So does anybody have anything?
Where do you get the test?
Sorry?
Where do you get the test?
So that's, so I guess that is the question that we...
If it's in Quest, then it's easy.
Yeah.
If it's not, it's through you guys, it's next to possible.
Uh-huh.
So it's,
yeah, I think
and I don't want to speak for everybody else, but I have the vaguest idea what the difference is. I changed the name one year, and then all of a sudden it's two diseases. So I have no clue what to order, whether anaplasma is the same as Ehrlichia or they're different.
Okay, so we can talk about it a little more. That's cool.
I have no clue.
Okay, so there...
I think the guidance came up whenever that if you're testing one outside the context of, like, say, obviously Lyme or whatever, that you should test for all of them.
Yes, yeah. And I think that in the back there you did see that if you haven't picked it up, there's an advisory that we put out last summer that has a tick-borne disease diagnostic algorithm in it, and so hopefully you'll find that helpful. And yeah, I think that the point of this slide is to show that we can't differentiate clinically between these two organisms. They are two different organisms. They are similar Yes, microbiologists do love to change the name and the taxonomy of things. This happened right when I was first practicing horse veterinarian, and horses do get anaplasmosis as well. So when I was in school, it was Ehrlichia equi, and then by the time I got out, it was Anaplasmosis phagocytophilium. It's a hard one to roll off your tongue. The reason why we see more anaplasma in this area and less ehrlichiosis is that anaplasma is carried by our most common tick, the Ixodes scapularis, and ehrlichiosis is carried by the Lone Star tick, which we see less frequently. And so you'll see as we go through that the case numbers for ehrlichiosis in our area are actually quite low. So yes, if you're like I know I just said don't run huge tick-borne disease panels, but certainly you can't differentiate clinically, so running a PCR for both of them would be appropriate. In acute disease, you should definitely, and if you are doing serology, then in order to diagnose the case and confirm it, we need an acute and a convalescent. And we all know what a struggle that is, like who wants to come back and get their blood drawn again once they're feeling better. So that's a real struggle. So that's why we are encouraging doctors to use the PCR. I think that's basically what so then this is our slide that is more about the diagnosis of anaplasmosis and ehrlichiosis. And so the other thing I will say is that it can be seen on a smear. Like I said, horses get really sick with this disease, and so I saw a lot of it in practice. I made so many smears in the beginning. I never saw those damn moruli. I looked and looked. So only 20% will be visible. So again, I think the take-home message is that PCR is definitely the way to go. And I'm not going to discourage anybody from looking for moruli. But
again, the same question. As opposed to Lyme disease appear to be real diseases with sick people who get better if you treat them. And so when you have someone who has 4 days of really high fever, possible tick bite, and low white count, that just as easily be virus as it could be Ehrlichia or Anaplasma, you end up treating them. So if you get a PCR in 4 days, what good is that?
And I will tell you that with my horses, that is the way that I ended up going with it, because most people don't have insurance, and by the time for horses, they'll have very high fevers that'll be gone in 12 hours with 1 dose of oxytetracycline, and so I was essentially treating based on response to treatment, or diagnosing based on response to treatment, not, not based on diagnostics. But I'm in public health, and I like to count things, and I think that there actually it is nice to know what the burden of disease is in our community. So I would still encourage you to test, but also certainly not to withhold, and that's the main point that's on that advisory that you guys see, is that we don't want to withhold treatment with doxycycline, especially in the summer months when we know that these diseases are happening with some frequency for patients that you have a strong suspicion of tick-borne disease, because we know that they can be hard to diagnose with lab diagnostics in early stages of disease, and we know that there's a lag time between when you see your patient and when you're going to get your results back. Okay, so again, we can see, I'm not going to get too stuck on this again because this is not a disease that you guys are seeing a lot in your population, but we can see that the rates are certainly going up for anaplasmosis. We can see that, like Lyme disease, we are in the hotbed here for anaplasmosis. And then this slide is showing our county rates, and that they're basically stable. So if you look at them from year to year, we don't have such a high number of, you can see the little fluctuations because we're talking about cases in the 60s and sometimes up to 70, and it's pretty much a little from year to year, but that's how it goes. So then we move on to Ehrlichia. Like I said, it presents similarly. Cases are also increasing, but again, this is not highly endemic in our area. We get a handful of cases every year, and that's because the tick is not as prevalent in our area. And this is just displayed on this map here, that we can see that the burden of disease for ehrlichiosis is further south of us predominantly. And then this is our county data for ehrlichiosis, and you can see because the numbers are so low that it, kind of goes up and down like a sawtooth.
How many is that?
Sorry.
Ehrlichia, 1 or?
So in 2014, we had 4 cases total.
Okay, so you do see it, okay.
We see it, but we see it, not frequently. Exactly. Sorry to. Yeah, if I rush through something, like I said, there's a lot of material, so if you see something on here that I don't touch on that you're interested in, we're a small enough group, just let me know.
So it's enough that we should be checking for it.
It's enough that we should be checking for it, and also if you have a patient that has a history of traveling to the south, then, that's one that you might be even more suspicious of than a patient that never left this area. All right, so we're going to go on to babesiosis.
Question.
Sure.
So what's that test called? Ehrlichiosis PCR?
Mm-hmm.
The other one's called Anaplasmosis.
Yep. So we have anaplasmosis and Ehrlichia. There's more than one Ehrlichia organism. Ehrlichia chapiensis is I think is the dominant organism that's causing ehrlichiosis. The other one, Ehrlichia wingii, I think there's only been 20 cases documented over a fairly long period of time, and there is cross-reaction between those organisms, so on the serology. So if you get a positive, you're actually covering for all of them. All right, babesiosis. So this is a red cell parasite. Again, the records that I see coming across my desk of people who are get really sick with babesiosis are the elderly and people without spleens. So I can't say that I see too many pediatric babesiosis cases coming across my desk. Has anyone in this group diagnosed babesiosis in there? Yay, one. So it's something that we need to be aware of. There's a couple points that I wanted to make on this. We already touched on, again, PCR is probably your preferred diagnostic in the acute period. This one you can see with more regularity on a smear than you can with anaplasmosis. So if you request a smear, if you have a patient that's in hospital and they can look at it right here, then that's really your fastest result that you can get to give you an answer. So if you see it on a smear, that is a confirmed diagnosis, but it's not a rule out because sometimes the parasite load can be so low that they just don't see it. The other point to touch on, and I have it as a separate slide, is that there is an issue with babesiosis in the blood supply. So we would like to encourage you guys that if you have a patient that you suspect babesiosis in, to include questions about donating blood or receiving blood in your history. This has been acknowledged that there are cases of babesiosis that have been transmitted through the blood supply. It is something that we do surveillance for, but if you guys don't ask the questions, then we don't know about it. Additionally, it is something that the FDA is looking at. There are studies going on right now for several different tests for how can we test the blood supply to try to screen it for babesia, and so that's something that's coming, and it's not there yet. They have to actually have a marketable test that they can do, but it's something that is being looked at right now. Okay, and then the other thing, again, we only have one person that's ever diagnosed with babesiosis, so I don't want to get too stuck on it, but something that has come up this year is that we have had clinicians say that there can be an issue with access to one of the drugs to treat babesiosis called atovaquone. It's extraordinarily expensive. It's not included in the formulary of all of the insurance companies. There are pre-authorization requirements. Many of the insurance companies include pre-authorization, and so if you do end up scripting this drug, if you have a patient that you think is uninsured or underinsured, for instance, if you have a patient that's in hospital and is being discharged with a script for this drug, you want to make sure that you tell their case manager so that they can work with this patient to make sure that they get access to the drug, and be prepared to give the insurance whatever proof of infection they require for pre-authorization. Otherwise, patients can end up paying over $1,000 out of pocket for this drug. Okay, and so again, this is just showing that we're so lucky, the upper Midwest and us, once again, we are the hotbed for babesiosis in our area, and these are our Dutchess County numbers, and they are going up gradually, and again, it's a small enough number that it fluctuates a little bit from year to year, but the trend is going up. All right, so this is our reminder of the diseases the tick-borne diseases that we see in Dutchess County. They all predominantly have their onset in the summer months. So this is just kind of reiterating what we were talking about with that advisory, that went around that if you see cases that you're suspicious of tick-borne disease in the summer months, we want you to have a high index of suspicion for tick-borne disease in the summer months, and we don't want you to withhold treatment for tick-borne disease while you're waiting for diagnostics, especially at the time when infection is highly likely.
So enterovirus runs running through the county in June. Supposed to get tick panels on everybody.
You know, I don't think it's appropriate. I think that comes down to your clinical judgment, and part of that is that you are paying attention to what is going around in the county. And so, you know, I'm not going to underestimate the difficulty of the task of being a clinician and making rational decisions. So I think that, you know, that is going to come down to your own clinical judgment to a certain degree. Does that adequately answer that question?
Well, you know, I'm sure the answer to all diseases around Hyde Park is 1,000 times more than any other area. So it really... Yeah,
it is, and that's why you don't buy a house in Hyde Park, exactly. So definitely don't invest in real estate there. Okay. And this is a slide of our advisory. And, you know, the one thing that I did forget to mention about anaplasmosis and ehrlichiosis is that doxycycline is the preferred treatment for those diseases, even in the pediatric population. That is the recommendations from the Academy of Pediatrics and from CDC, and they have done studies to show that children under 8 who had up to 5 different courses of doxycycline at the recommended dosage rate didn't get permanent staining of the teeth. So the reason for that recommendation is that they're really, you know, for Lyme disease we have other choices, but for anaplasmosis and ehrlichiosis and Rocky Mountain spotted fever, doxycycline is really, we know that the outcomes are best with doxycycline, and so the risk-benefit ratio falls on the side of treating with doxycycline. That's probably the most I'm going to tell you guys about how to treat your patients, because I don't like to go there. Go ahead.
How long does Lyme titers stay elevated after?
Oh, boy, I wish that I had a solid answer for you on that, and I think the fact that we don't have a solid answer is highly problematic. So, interestingly, in veterinary medicine, the typical 2-tier testing that we're doing now for humans is considered old-fashioned, and so in veterinary medicine they're actually monitoring titers to specific antibodies to OSP and OSPF that are outer surface proteins on the organism, and they've tracked how quickly these go up and down with treatment in dogs and in horses, and so you have more to go on. And I'll tell you that I was in a lecture from the clinical pathologist that developed that test at Cornell, and I asked her, I said, how come, you know, nobody has asked you to work on modifying these labs for use in human beings? And she wouldn't answer. She wouldn't go there with me on that. And so all I can say is that Lyme disease is a really tough area to work in with a lot of controversy, and I wish I had a better answer for you on that. I will tell you that in terms of our case definition, if a person has been a case of Lyme disease in the past, in order to be a confirmed diagnosis for a second time, they have to present with an EM rash. So you can take from that what you will, but basically that is the CDC and the state saying that is the degree of confidence we need to say that it is definitely a new case of disease, because we know that we are using serology and we know that things can stay positive for such an extended period of time.
I mean, correct me if I'm wrong, anybody knows different, but I always read that you could take the same Lyme serology, put it in 3 different labs or 10 different labs, get 10 different results, and even do it in the same lab 3 times a day and get different results. So in terms of the titer, which makes following titers worthless, that's the way I've always looked at it. Does anyone else have a different perspective?
I wouldn't say that it's that bad. I mean, certainly your ELISA titer, you're getting a number, but when you're doing a Western blot, it's going to depend somewhat on the skill of the laboratorian that's looking at it and reading those out. When I was reading more of those results before we changed to the multiplex IFA in veterinary medicine. The laboratorians would often comment on the strength of the banding pattern, and so as a clinician, I would use those comments to try to extrapolate as best I could what was going on with the animal's immune response. But like with many things with this disease, the answer is that we don't have a solid.
I mean, the banding pattern, if I have 2 bands or 10 bands, I do get that some credence, but the number of the titers is 100% worthless. Okay.
Yeah, no, and I don't think.
Yeah, 100% worthless.
Yeah, so.
Mom says, well, is it going down?
Yeah, no. I don't think that, and I don't think it's meant to be used that way, really. I think once it's in the positive range, we're just using that as a screening test to go on to the second tier, which is your Western blot. Okay? All right, so now we're going to move on to the things that are maybe a little bit more exotic. The purpose in doing this is to have you guys have an awareness of the things that are here in low levels, and also just give you our perspective on some of the things that you might have heard about in the news as well. So the first one is Powassan virus disease. I did mention this. This is a flavivirus. I feel like I'm spending my life drowning in flaviviruses this year with Zika. So it is a cousin of Zika and dengue and those things. However, it is carried by a tick in our area. It is predominantly carried by the Ixodes scapularis tick. There's actually 2 very, very closely genetically related viruses that cause an identical disease so that you can't differentiate them serologically. The lineage 1 Powassan virus is transmitted by that Ixodes cookii, the woodchuck tick that I told you guys have to work really hard to be bitten by. So we don't think that that's probably the one that's actually causing most of the disease. Lineage 2, which is also called deer tick virus, is the one that is found in the I. scapularis tick. The thing that gives folks in public health a lot of grief about this disease is that one of the main things that we talk about for prevention of tick-borne disease is early removal of ticks, and we know that for Lyme disease, for anaplasmosis, for babesiosis, that there is some degree of a grace period, meaning that as soon as the ticks attach, they're not transmitting the disease. They have to go through some immunological mechanizations inside themselves in order to actually be transmitting the disease. So we know we have like 36 hours roughly for Lyme. The time frame isn't quite as solid for anaplasmosis and babesiosis, but we know that there is a grace period there and that it's probably about a day. That doesn't exist for Powassan virus, so it's been shown to be transmitted in as little as 15 minutes. So this is a disease that scares us because the clinical spectrum is pretty severe. So we have a 10% mortality rate. We have really severe neurological symptoms, and 50% of patients that do have these neurological symptoms have permanent deficits, and there's very few tools in the toolbox for prevention for this disease, or treatment for that matter, because it is viral. We have a specific treatment. So the only, good news about this disease is that luckily it's quite rare. You can see that in New York we have the second highest rates, but that there were, let's see, where's my time span, 2004 to 2013, 17 cases overall. Okay. So if you do suspect this disease, this is something that the testing is only done at the public health laboratory at Wadsworth, and the interpretation, you'll end up having some conversations with me on the phone because it's like all our flaviviruses, it's complicated to look at all these different tests that they run and interpret. So this is our Dutchess County numbers for Powassan. So you can see that we have had 3 cases from the 2004 to 2014 period. Any questions on Powassan before we move on? I don't know if you guys have heard about this one. This is Borrelia miyamotoi. It is a Borrelia organism like Borrelia burgdorferi that causes Lyme disease, but they're very distantly related, so they present differently, and its Borrelia miyamotoi is really more closely related to other spirochetes that cause relapsing fever disease. And so clinically what you're going to see is a presentation more similar to anaplasmosis than to Lyme disease. And at this point, like I said, it is not a reportable disease, so we don't really have a handle on the levels of disease in our area. We do anticipate that sometime in the future it will, in the not too distant future, it will become a reportable disease, but in order to do that, we have to have more lab capacity for testing, and right now the only lab that's doing testing is Imugen in Massachusetts. They do run a PCR for acute cases and serology as well, and it is responsive to doxycycline. Okay, so then we get on to the diseases that at this point have not been found here in our area, but you may have seen on the news, and so your patients might ask you about, so it's good to have an awareness of. And also the reasons why we've mentioned these is that they have been found in ticks that we have the geographic range that exists in our area, and so we need to sort of keep an eye out for if they could move into our area. So this is the latest one. This got some press. It was announced on the 8th of February. It was found at the Mayo Clinic. What they do at the Mayo Clinic is they ran, I think, over 100,000 different blood samples that were submitted for testing for Lyme disease. They run a PCR test for Lyme disease. PCR is not highly sensitive for Lyme disease because the spirochete doesn't spend a lot of time in the blood, and so the blood levels are really, really low. What they did find was that they had 6 positives that had a different pattern on PCR, and they, did genetic analysis and found that this is actually a new organism. So we're only talking 6 cases. They were all from the upper Midwest, and they can be detected on PCR because you have a much higher level of spirochetemia in acute disease. It's a little too early to talk about what the clinical presentation is of this disease versus Lyme disease because we only have 6 cases to go on. But it does seem to be similar. I think they've seen more diffuse rashes here with this disease than they have with Lyme disease, and it seems to be also sometimes associated with GI symptoms. It appears that this does cross-react with Borrelia burgdorferi, and so that we will probably pick up these cases on, or not pick them up as being a different organism, but that they will probably be positive on the testing that you would routinely do for Lyme disease. But again, with only 6 to go on, it's hard to know for sure on that as well. And again, happily, we can treat these with doxycycline as well. All right, this is another Ehrlichia organism that has been found in 4 patients from Minnesota and Wisconsin in 2009, and then this finding made them do a retrospective study of more blood samples, and I think moving forward as well for a few years up to 2013, and so total there have been 69 PCR positives for this disease. It presents like our other Ehrlichia organisms, and so far it has only been found in the Midwest, in Minnesota and Wisconsin. But the reason why I mention this one is because the Ehrlichia chafiensis that we were talking about earlier is found in that Lone Star tick that we don't have in as high numbers as we have the I. scapularis tick in our area, but this tick was found in, this organism was found in I. scapularis. So it is something that we have to have some awareness of because like I said, we see low numbers of ehrlichiosis in our area, but if we have an Ehrlichia organism that's being carried by I. scapularis, then that could be something that changes in the future. And I swear we're getting to the end. So these are the really rare ones at this point and the really new ones. Heartland virus is a novel flevovirus. And when was this one found? 2009, so flevovirus, so again, as a veterinarian, this strikes fear in my heart. That's a Rift Valley fever relative. They think that it is transmitted by Lone Star ticks, but again, there's not enough cases to know that for sure. And so these patients, they present like another patient with tick-borne disease, so fever, thrombocytopenia, leukopenia. You might be thinking that this is an anaplasmosis case, but because this is a virus, these are not going to respond to doxycycline. So I think the take-home message in this is that if you have a case that you're highly suspicious of tick-borne disease, and they're and it's not babesiosis, and they're non-responsive to doxycycline, then this is probably one that you should be on the phone with public health about, because maybe this is something that's at least worth having them have a look at the public health lab. And the same goes for this last one, bourbon virus, that was found in exactly one person, a fatal case in 2014 in Kansas. And again, you know, similar, we only have one case to go on, so you can read for yourself how he presented. Whether that's a classic presentation, you can't say based on only one case, but the same. This is a viral disease, and so again, it's not going to be responsive to doxycycline, and so if you have something that you think is an oddball, that's the time when you get on the phone with us, okay? So that's kind of a run-through. I'd like to thank Andy Evans, who this was a presentation that he had created in the past that I adapted and updated, so a big thanks to him. Veronica Salvis is our biostatistician at the health department, and she updated the local epidemiology slides. And then, of course, our own department and the New York State Department of Health and the CDC website supplied a lot of the content for this presentation. So I think we've done questions as we went, but I'm happy to take any other questions that anyone has. Okay.
I'm sorry, I came in late. When you were talking about the newer Borrelia that was identified in Minnesota, not exactly.
Mayoni.
You mentioned that in response to doxycycline, and certainly with the Anaplasmosis and the Ehrlichiosis, we need to worry about doxycycline. As pediatricians, we
are hesitant to give doxycycline
very, very early. So I know that all the ID people say that we can use it, but it's not our first line thing. Do you know with, for example, that Borrelia, does it respond to amoxicillin, which we can use in our kids more often? When it comes to the other guests, kind of take that leap of faith and that guess to be able to say, yeah, we're going to use doxy in this 3-year-old.
Yeah, yeah, I understand that. Let's go back to.
Yeah, that's okay.
Yeah, so I have to look back at this paper. So the source paper is at the bottom here, and I can't tell you for sure if I remember exactly what, and again, this is only 6 patients, so it's not a lot to go on what they treated them with, but I didn't write down exactly what, and I know they did actually lay out what patients were treated with what, and I think the majority of them were doxycycline, but I think one of them was treated with a cephalosporin. I just don't remember off the top of my head. So we did discuss earlier that, you know, that we're aware that pediatricians are hesitant to use doxycycline, but the guidance from both CDC and from the Academy of Pediatricians is certainly in cases of anaplasmosis and Ehrlichiosis that it is the drug of choice, and that the risk of tooth staining is low, and you have other options for Lyme disease, certainly, but if you're not sure which one it is, I think that, you know, I'm a parent. I have 2 10-year-olds. My choice would probably be err on the side of using doxycycline.
Could you just do a brief overview of the Zika virus and what we should know and be able to tell our patients?
So I will be doing a talk on Zika virus in May. I believe it's May 12th or May 13th. I'll be doing a grand rounds for the obstetricians on Zika virus. I don't know if you guys are able to attend each other's CME sessions, but I certainly don't feel that it needs to be limited to obstetricians. Boy, how to summarize Zika in a nutshell, what you should be telling your patients. So Zika virus is the primary concern for Zika virus is in pregnant women. So we know that until it was recognized that Zika has been correlated with all these terrible birth defects in children and babies, Zika was thought of as a relatively mild illness, and so it wasn't given a whole heck of a lot of attention. So we know that the presentation is somewhat similar to some of the other arboviruses that patients might get if they travel. However, it's probably milder, and there definitely is study of there being a link to increased rates of Guillain-Barré syndrome afterwards, but for the most part, we think that the clinical presentation is of somewhat milder illness than things like chikungunya and dengue virus. So right now, there is no local transmission of Zika virus in the United States. In our area, we do not have the Aedes aegypti mosquito, which is thought to be the primary vector of transmission. Just south of here, we do have a mosquito called Aedes albopictus that has been shown in the lab to be able to transmit the virus. We think that the northern range of that mosquito is in Westchester and the middle of Rockland County. Sorry?
That's pretty close.
Yeah, it's getting close, and so it is something that the state is going to be monitoring the distribution of. And, but again, I think that in terms of transmission in the United States, we can use the history of chikungunya and dengue in the United States is probably going to be instructive in that those viruses are transmitted by the same mosquitoes, and the vast majority of cases that we've seen in the United States are travel associated, and that has to do with the fact that in the places where Aedes aegypti is common, we do really good mosquito control in the United States, and also we live differently than they do in some of the other countries where they're really seeing epidemics in terms of having screens on our windows and air conditioners and being, frankly, having less impoverished cities where there are lots of open container breeding sites for these mosquitoes. So I think in terms of local transmission, there's reason to be optimistic that we are not going to have a rampant epidemic in our country. However, I do think that we need to provide our patients that are traveling with guidance, and certainly the caution should be predominantly for pregnant women, but there also needs to be considerations for men who are traveling that might be returning, and if they have pregnant partners as well.
I remember Aedes and Albopictus and Aegypti are day-biting mosquitoes.
Yes, that's true.
It doesn't really matter if they have screens and windows, because our Americans go out in the summer. They play soccer.
Yes, it's true. I think it's a matter of degrees. So these are also mosquitoes that like to live in neighborhoods near people, and they like to live inside houses. So I think that it isn't that there isn't risk of exposure, but it is looking at sort of all the determinants of risk and saying that overall our risk is lower, and also just the degree of, Andy and I attended a conference about how New York State is going to look at mosquito surveillance and control, and the mosquito control guys just absolutely pray to the Florida folks that do mosquito control. So I think that
the other side of the world, they have already a vaccine for dengue.
Yeah, so I think there's 3 countries now where a dengue vaccine has been approved, and Philippines, Brazil, and maybe Malaysia. And so it would be really wonderful if we had a vaccine for dengue virus that we could offer to patients before they traveled, and certainly there's also a big scramble of research going on to try to get a vaccine for Zika virus as well. These are big epidemic problems. They're, for someone like me who is a student of One Health and looks at emerging infectious disease and spends a lot of time thinking about that, we know that it's a really complicated issue that has its roots in globalization and climate-related factors and overpopulation and how close we're living to animal populations, things leaping from, because even Zika virus was originally found in primates, not in people, and then, when it makes, and this is what's going on. So 70% of emerging infectious diseases are zoonotic. So, hence you have veterinarians working in public health.
She just mentioned the one thing that we don't have here is primates running around, other primates other than us. And that's the other
yeah, that is helpful.
Going.
Right. So we don't have the leaps here, but for dengue and for chikungunya and for Zika, the cycle is mosquito to human now, and people are the reservoir, because we do have. So for some diseases, like if you contrast it with West Nile virus, which came here, and I do see your hand. You're next. in 1999, we know that people are not the reservoir for that disease because we don't have high enough levels of viremia to transmit back to infect mosquitoes. So we know that birds are the reservoir for that. So these diseases are a little different because we know that people are the reservoir. Go ahead.
I have a couple of questions on this.
Sure.
So you said the male partner returning, is that because it's sexually transmitted?
Yeah, so in the beginning when people were calling me and saying, but I heard this report that it's sexually transmitted, I could say, oh, there's only one report, we can't say that with certainty yet. And so the evidence is absolutely mounting for sexual transmission. It's been found in so epidemiologically, it's been linked, so there are women that have not traveled and their only exposure risk is unprotected sex with a partner who has traveled. And in fact, I think the only cases they found it in is with partners who were symptomatic. So we know that 80% of Zika infections are asymptomatic, so they have not, it doesn't mean that it isn't possible, but it hasn't been documented yet that an asymptomatic male has transmitted to a female. But it has been found in semen up to 62 days out from infection. So the current CDC guidance is that if you are a male person that has traveled to an area where Zika virus transmission is going on, and if you have a pregnant partner, then you should either abstain from sex, all kinds of intercourse for the duration of the pregnancy, or use condoms consistently for the duration of the pregnancy. And that's because we don't know how long it can remain in semen. And again, there's so much, there's people working on all these different things right now. It's a big scramble.
And the anencephaly.
Microcephaly? Yep.
Microcephaly.
Sure.
Occurs if the woman gets infected in the first few weeks, or?
You don't have a definitive answer for that either. They do think that the risk is higher in the first trimester, so there's case control studies that are going on right now to try to get a better handle on what the window of infection is and or for when the window of infection causes what congenital defects. And so the evidence so far is showing that that the first trimester, like many of the diseases that are, teratogenic, is the most dangerous period, but we don't know that for sure yet either. Sure.
Now go to Lyme disease for a second.
Okay, switching gears.
Is there anything in the legitimate scientific literature that says that Dr. Horowitz is not a complete quack?
Wow, are you, I would ask you to Google his, I just watched a video of him singing his Lyme song in front of a lot of people, and then you can, I think that we all have to make up our own minds on that one. Is that a good answer? Okay.
I do have a related question to that one, but as far as with Zika, for us, we have that overlap just because we think
absolutely
we're going to see the, pregnant women as well.
Yeah.
As far as, maybe not large swaths of our population are going to be maybe visiting the Caribbean, but what about, like, people who are going to Florida, the Carolinas, and
So, like I said, for right now, there is no local transmission in the United States, and that we can answer definitively at this point. That may change, but I think, so for instance, if you have a patient that comes in and they say that they have this travel history and you're trying to make a decision, should this be on my differential list or not, you can either call me, I'm usually at my desk, or on the CDC website, they have, if you just put in Zika map, you'll see a map of all the countries where there's local transmission, and then you can also get to a table that'll show exactly how many cases have been confirmed in each state of the United States, and then they break it down by travel associated and local transmission, and my life will get much more complicated. For right now, the local transmission is all saying zeros.
And then just related, like I was telling my group earlier that I had a patient last year who I really, in my heart of hearts, believes had chikungunya based on her symptoms and travel history. And I ended up getting, diagnosed and treated for Lyme by infectious disease. And so taking into account patients with travel history and that whole range of diseases, do you have any opinions, guidance?
Yeah, absolutely. I think that it's important to ask specific questions about the travel history. I mean, that's the start, right, in your history taking, and I'll tell you that, the records that I see come across my desk, again, I'm only seeing what gets actually written down, but a lot of times when the nurse or whomever in the practice is filling out the reporting form for travel history, it's almost always circled unknown. So I think the first step to having a suspicion is to know to ask the questions. So we need to ask the questions about the travel history. I can't keep all the incubation periods and everything in my head, and so I know that you guys look at a wider range of diseases than I do, and so I certainly don't expect you to do that, but if there's a travel history, I don't think it's unreasonable to say, well, let's look on the CDC website. It's a fabulous resource to see what diseases that you might not be familiar with are circulating in that area. What is their incubation period? What are their symptoms? And see if it should be on your differential list. So in terms of the arboviruses that we are seeing coming in from the destinations that we have people traveling to frequently, like Mexico and the Caribbean, dengue and chikungunya and Zika all present in a similar enough fashion that you're not going to be making a diagnosis based on clinical presentation alone. And so when you are testing, we should probably be testing for all three. Again, you're saying, okay, well, there's no specific treatment for this. My patient isn't pregnant. It's a, 8-year-old girl who isn't likely to be causing a sexually transmitted infection. Do we really need to know which one of these it is? That's just kind of anticipating the next questions. But I think that certainly for dengue, it's important to know, because if you have a positive dengue, then you want to be more alert for the possibility of severe disease, which can occur in the time when the fever is decreasing, and then those are patients that need to be hospitalized and treated aggressively, symptomatically treated, but treated aggressively to avoid mortalities. And that risk doesn't exist with chikungunya or with Zika for the most part, and so making that clinical differentiation is important. And then also, I think, again, we like to count things, so knowing what the burden of disease you're adding to the body of evidence, and all of that information, I'll just make a plug for why we want to know these things, is because that's the information that you guys use to start your decision-making process for diagnosis. How much of a clinical suspicion should I have? If we don't have numbers, if we don't know how prevalent these diseases are, then you guys don't have that basis, that piece of information on which to make determinations of how suspicious you should be of one thing over another. Mm-hmm.
Hi, good morning. Thank you for your presentation.
You're welcome.
I just have a quick question. If we have a parent who comes in for their child's routine physical, and the child had maybe a tick bite a couple of years ago, mom wants to just throw in Lyme titers, and do you advise doing it? The child is asymptomatic. And if we do it, and let's say we get a positive IgG, but the child is asymptomatic,
then what do you do with the information? That is, that's a difficult, it's easy for me, from my position, to tell you, no, I don't recommend that, please don't do that. So it's very easy, for me to say that. I do think that I have, and again, because I was a clinician, I do think I have an appreciation for the pressures that you feel as clinicians from parents and from patients who are asking for diagnostic tests. And so that said, I do appreciate that. What I would say is that, first of all, in terms of there being a history of a tick bite, if we were in a different state, then that would be a somewhat more meaningful history. But we know that in this state, most of the tick bites that people get that cause disease they never know about in the first place. So we know that most of the cases of disease happen in the summer, and that the nymphal stage of the ticks is what's out for the most part in the summer. We know that that's our main source of disease, you know, based on the epidemiology. And when you ask patients, do you remember getting a tick bite, most of them don't. So you know, my response is it rational to test on the basis of there being a known tick bite? You know, maybe not, because we don't know if there was another exposure at another time. Now, that's only the one that you know about. There might have been many, many different exposures. And so what I would say is that if we start routinely testing, or if you are routinely testing in asymptomatic patients, well, you know, when I was a clinician, I always thought, if I'm going to run this test, do I want to have to deal with the implications of of the decision that I'm going to have to make if I get a positive? So I guess I would say to factor that into your decision making when you're deciding to run the test or not.
Data out there is one of the things that we're talking about as far as the testing, knowing that it's not the best quality testing on people who are not symptomatic or obviously symptomatic.
Yeah. So I think that the data is showing us that people can maintain a titer for years, and so how meaningful, if you don't have a history of there ever being, and that still leaves you with the question of, so what if you have somebody who's asymptomatic with positive labs that never has a history of being treated for Lyme disease in the past? And we deal with this with animals, too. And I can tell you that in the veterinary world, most people are recommending a course of treatment. I don't know. And again, treatment isn't, I'm very careful when I'm talking to.
The secondary question is, can you clear a Lyme infection without antibiotics? Or if you were never treated and you have a positive titer, that means you still have Lyme.
It doesn't mean
well, that's the heart of the, that is the question. I don't think we know, so I'm going to tell you I don't think we know that.
If you look at the AAP,
I don't think that we know, I do not think we know. Okay, that kind of goes back to his question.
But let's look at what happens when you treat an asymptomatic patient and you get a positive test. First of all, the test is relatively useless. Second of all, what are you going to do? You're going to treat and the kid's joint pain doesn't go away. That's the patient you're going to send right into Horowitz's arms because your treatment is treating the air and you get a patient who doesn't get better. What a surprise, because he never had the illness in the first place. And I never treat asymptomatic tick bites or I never test.
It's not the question of asymptomatic tick bites. It's in the context of that we know that the test we have for Lyme disease is, as of this moment, not the best test that we would want. You know, how do you put that together with what you know is a high prevalence of illness? Not for the fact of the people that we know that have chronic, vague symptoms that you could put them in any number of categories of, you know, chronic fatigue, fibromyalgia, blah, 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 blah. That someone who has something that seems somewhat legitimate, what of these variety of testing that the Lyme literate people do have any validity?
Mm-hmm. I think that they're really valid questions that you're asking. I don't think that I'm probably the most well-versed person to answer those questions. I'll tell you that up front. Have I done my own extensive research on all the different tests that those doctors are using? I have not. I know that there are, for instance, there's a lot of stake put in a positive IgM. We know that that there's a lot of cross-reaction for IgM, that can carry on for a very long time. So I know that that is one scenario in which, you know, the Lyme literate doctors are perhaps recommending.
Stop calling them Lyme literate.
I had air quotes.
Okay, please.
So we know that they're using PCR as well. Like I said, PCR is not perhaps an appropriate test for Lyme disease because we know that there isn't a high level of spirochetemia. But I think that these are really valid questions. They frustrated me as a, so as a clinician, as a veterinarian, I would ask the folks doing research on Lyme disease, we would say, we would sit in a room like this, so the Hudson Valley vets, they don't. They present with high fevers with anaplasmosis, but with Lyme disease, it's a much milder, it's even harder to diagnose. It's absolutely a very, very subtle illness that you really can't diagnose on physical exam. So one would question whether to definitively diagnose Lyme disease in a horse, it's essentially a post-mortem diagnosis of a Lyme neuroborreliosis. We're off the subject. But essentially, what I'm saying is that...
Hey, don't get anxiety.
What I'm saying is that I have asked the same question. So as a clinician, I'm looking at this report and I'm saying, it's saying that the banding pattern is darker for this time when I did the Western blot than it was when we did a blot a year ago, and so we're thinking that the antibody titers are over. Is it rational to say that that is a reinfection versus simply having antibody titers that fluctuate over time? And the answer is we don't know if that's rational or not. So without an antigen test, it's really difficult to answer those questions.
I think also if you have an experience of a very rare...
I'm sorry, I need to do a Marco Rubio. Okay. No, go ahead.
If you are a doctor and you have an experience of a rare presentation of Lyme, like a brilliant student, and suddenly deteriorated as an academic deterioration, and then some wisdom, out in the ground said, why didn't you test for Lyme? Mm-hmm. They did a test for Lyme, and it was positive. It turned out to be neuro Lyme. They had a spinal tap. Mm-hmm. Treated, and the kid went back to track. Mm-hmm. So if you are the doctor and say, hey, neurobehavioral changes, is this a potential neuro Lyme? So that's up in the air. So that's why your threshold of probably screening and testing for all of the things that you cannot explain will go up.
Well, I think that there's no denying that this is a really tough clinical environment that we're all, well, you guys more so than me. I'm safe in the office where I get tons of Zika calls all day. But this is a tough clinical environment that you guys are operating in, and these are valid questions that you're asking. I think, if you have to ask what my own personal sense is on it, I think that what we have is a large pool of populations, a large pool of patients that we are having trouble getting to a definitive diagnosis on, and so a lot of them are, so in a lot of cases we're going to this Lyme disease diagnosis, and like all things that kind of go on a continuum, there is probably a small, there's probably a percentage of those patients that truly do have Lyme disease, but we don't have a way to differentiate those right now, and that's a really big problem. It's a problem for us with counting. It's a problem when, there's legislation being pushed to try to handle this, and we don't have the scientific legs to stand on to differentiate which is which. I think that it's really important to not, because, so I once heard a veterinarian describe trying to diagnose Lyme disease as trying to catch smoke. And so that's true, that, and in some of these cases we're almost ending up with it being like a rule-out diagnosis. And so I do think that it really underlines the importance of checking for the other things that are on that rule-out list and not jumping to Lyme disease first. And that's really hard work, and I appreciate that. And sometimes it's hard to definitively get a conclusion on some of these other things, but that is where we're at with this disease. Yeah.
I just wanted to make a comment before when you were mentioning the IgM that I heard a number of speakers kind of commenting on how unreliable it is, and having just watched it then in a lot of the kids where I'll see a positive IgM. If that's a reliable thing, it should fade away into the IgGs. It's going to show up later, and it just doesn't. And so I've always been given the advice, I can give out the advice that basically the diagnosis should never be made on the IgM.
So with our case definition, in order to be confirmed, in order to have confirmed labs, you have to have, positive first-tier titer and then a positive Western blot, and if you're positive on IgM only and not IgG in order to confirm the case, the onset of symptoms has to be within 30 days of that positive IgM. So that's an acknowledgement of the fact that these things. Right, and exactly. So if and so that is, you know, again, underlines the importance of going back and getting that convalescent specimen if our goal is to get to that definitive diagnosis. And, you know, I understand that there are pressures on clinicians other than, you know, sometimes that goal of getting to the definitive diagnosis is not, you know, the only thing on your list of important things in order to treat that individual patient. So when we're looking at populations, that's really valuable to us because that's how we count. But, you know, you have to, I switch hats between the clinician and, you know, looking at this from an epidemiological perspective. And I think one of the biggest goals for us in coming here, in addition to, you know, providing education on specific topics, is that it's, I just think, really hugely valuable. We really value our partnership with HealthQuest in having public health and clinicians interacting in general and working together, because the more siloed we are, the worse things function. So that's my little soapbox on that.
Getting feedback. We've learned a lot, whether it's STD, HIV, or this particular topic from you. That's why we left a little, like, brief, focus survey.
So it was our intention to try to do a focus group for anyone that was willing to stay after this lecture. We are trying to talk about some of those reporting issues that we talked about during the lecture, and trying to get some feedback from you guys, and working towards improving the numbers that we get to make them more meaningful. I understand that you guys have another meeting in this room afterwards, so we're not going to get to do the formal focus group, but those surveys, not surveys,